Good morning, good afternoon, and good evening, everyone. I am Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Welcome to this third webinar in a series on delivering quality essential maternal, newborn, and child health services in the time of COVID-19. Today's session will focus on maternal health, specifically on referrals and maternal complications. The series is co-hosted by the Network for Improving Quality of Care for MNCH and the Quality of Care subgroup of the Child Health Task Force, with the support of UNICEF and the World Health Organization. We will have today about 30 minutes of presentation with 3 different speakers, followed by 30 minutes of question and answer. You will see that you are all muted on entry, but please do engage with our speakers by typing your question and comment in the chat box. You'll see we send a few instructions there on how to do this. We will then have our moderator today read out the question at the end, then the second half, and the panelists will have a chance to answer them. We also encourage you to continue the discussion on our committee of practice. You can see a link on your screen at the moment on how to join, and we'll send you the link again. We're recording this session. We will send you latest tomorrow a link with the recording and all the presentation for today's session. I will now like to hand over to one of today's facilitators, Dr. Bleta Malici, who is a technical officer in the Department for Maternal, Newborn, Child and Adolescent Health and Aging at the World Health Organization. Bleta.
Good morning, good afternoon, good evening to all participants. This is the third webinar in the series of delivering quality essential maternal, newborn and child health services during COVID. As Benedict said, this is a co-organization between the Network for Improving Quality of Care for Maternal, Newborn and Child Health, a network of 11 countries, and the Child Health Task Force, that is a network and partnership of over 100 organizations, including government agencies, NGOs, multilateral and bilaterals, and academic institutions. So why this series? Quality matters. Quality at the time of COVID has become even more important. We know that safety, people-centeredness, timeliness, equity, integration, efficiency, and ultimately effectiveness have all been affected by the COVID epidemic. At the same time, the service delivery is challenged to maintain a normal delivery of care under very extreme conditions. So by now we know that those health systems and services that were prepared to deliver quality care have responded better. At the same time, all countries are adapting innovations and changes to ensure that quality is not implicated, and at the same time, everybody receives care. So in this series, we are now working with different partners and looking at organizing and discussing different types of activities that are related to quality of care, maintaining quality of care. So for that, the objectives of the series are to highlight the needs and opportunities to maintain and strengthen MNCH services during the context of COVID pandemic, and to share the global guidance and learn from country experiences. So for today, we are going to focus on a very important aspect of referral for maternal complications and maintaining the best service delivery in relation to this referral during the COVID pandemic. Today's webinar is facilitated by Dr. Tedbabe Haile-Gabriel of UNICEF, Dr. Isabella Sego-Moses of Ghana Health Services. Dr. Sago-Moses is a Deputy Director of Family Health in Ghana Health Services, and Dr. Roslyn Doe, who is the National Professional Officer on Maternal and Child Health Services in WHO Ghana. The speakers for today is a distinguished panel. We have Dr. Loveday Peng Kekana, Assistant Professor of Maternal, Newborn Health and Health Systems, and a Technical Advisor to USAID Community of Practice on Care Seeking and Referral. Dr. Chris Opoku-Fofi, who is a consultant on OBGYN on Family Health Division of Ghana Health Services. Dr. Yvonne Kiza Mugwerwa, who is an OBGYN, and she's the project director of Kampala SLA Maternal and Newborn Health Project, MANE project in Uganda. Without losing too much time, I'd like to hand over to Dr. Loveday Peng Kekana for setting the scene and facilitating our discussion.
Good morning, good afternoon, good evening. Just very quickly, I think we all know, even when we're not being faced with a COVID epidemic, that making sure that the women and newborns get to the right facility for the level of care that they need is a challenge. We have normal journeys where people go, but we also have a range of emergency journeys that women have to undertake to make sure that if the birth is going normally, they deliver one place, but they can get the emergency care if they need. Next slide. So in the COVID epidemic, we have heard a lot about various challenges that are making getting the women and newborns to the right facility at the right time a challenge. Women are reluctant to access services and sometimes particularly services which are known to host women, so sometimes tertiary hospitals, for fear of contracting COVID-19. We have heard that public and private transport, which is how women and families and newborns often get to facilities, is severely limited. Ambulance services are overwhelmed, partly because as there isn't other forms of transport, people are using this, and also issues around ambulances being used to transfer people with COVID. And also we've heard stories of drivers not and ambulance staff not being prioritized for access to PPE that's often in short supply. Another challenges that we've heard is that not all facilities are providing their usual services. Some services are now providing COVID services. Some services they're directing people to other services. So women and families are not always certain where to go, and also providers are not always certain where to refer women if they can't look after them. The other challenge that we're hearing is that because ANC attendance is dropping, and also that some women are choosing to deliver at home, maybe with traditional birth attendants, it means that a number of women are arriving in facilities very sick. And it's very hard for facilities then to help them because their problems haven't been picked up. The next slide, please. So these are not recommendations, but these are some of the national and local responses that we've heard about. And I particularly want to thank my colleagues in Nepal who have been helping me think through some of these issues. So strategies have been policies on allowing pregnant women and newborns to travel during lockdowns. Right at the beginning, this was sometimes a problem that health workers and pregnant women were not able to access. And so people thought about putting in schemes so that was possible. Increased use of telephone, telemedicine and digital platforms where possible. So for again, in Nepal, a system where people can phone with concerns to know whether they really do have to come to facilities. Telemedicine and digital platforms that are communicating with people. There have been a number of efforts in a number of ways, and I think both of the presentations to follow will talk about this, as efforts to produce up-to-date information on what services are being provided where, and sort of WhatsApp and other forms of communication for women, families and health workers. There have been some interesting initiatives of mobilizing community and sometimes community health workers, the private sector, as a way of sort of helping the strategy. I think countries are more and more recognizing the importance of provision of PPE for transport and emergency transport. Countries have been thinking very carefully about screening and separating patients and the whole sort of patient flow in maternal and newborn health services, and sometimes allocating some different places for well patients and others for COVID patients. And then another slightly more controversial strategy that people have been talking about is getting midwives to go to women's homes if they cannot get women to come to facilities. So these are the kind of things that we're hearing about. But now we're going to hear about what's happening in the Uganda and Ghana, and then after that I will facilitate a sort of conversation about what else is happening. Thank you. I'm passing on to Dr. Fifi at the Ghana Health Services.
Chris Opoku-Fofi, presenting Ghana's referral and transport strategies for maternal services in the context of COVID. Next. Ghana has the 4th highest confirmed COVID-19 cases in Africa, with about 129 fatalities already. In other words, we can say that COVID-19 is beginning to bite. Next. This is a trend of maternal mortality over the years. Next. Now, let's see how the situation on the ground now. There is a reduction in antenatal or hospital attendance, and that is because majority or some people are concerned about safety implications coming to health facilities. However, we still believe that maternal and child health remain key essential service to the country. As a result, strategies were put in place to mitigate some of these concerns, which at the end has led to improvement or stabilization of some of these indicators, which we'll be looking at next. Next slide, please. So here we're looking at antenatal attendance. All right. Antenatal attendance, and we see generally there is an increment across the years, that is from 2018 to 2020. However, in the COVID-19 period, starting from March to May, we see a decline in antenatal attendance, which began to show in April and got more severe in May. In other words, we can say that COVID-19 is beginning to affect antenatal attendance. However, when we look at deliveries, total deliveries, we also have a pattern. Over the years, there is an increment in delivery across the different months. But when we look at the months of the COVID epidemic, there hasn't been much changes. Therefore, it's fair to say that by the close of May, we still have very good delivery that is comparable to other months within the year and with the other months. Now let's look at maternal mortality. Over the years, there has always been a decline within the last 3 years. However, when we look at the COVID period, that is March, April, May, there hasn't been a significant drop. On the contrary, when we observe clearly the values within May, there has been a slight decline. So in short, I want to summarize that to mean that maternal mortality has stabilized. Finally, let's look at neonatal mortality, where generally the trend is downward. And precisely in the last 3 months, that is the COVID period, there is more reduction, rather having the lowest figures within May. So in short, we're saying that attendance has reduced, deliveries have stabilized, but we don't have that huge impact on maternal mortality and neonatal mortality, which means that if we sustain the services and continue these interventions, things might be good. However, let's look at the factors that are driving these indicators next. So first, the national policies, guidelines, protocols, including referrals, are still in use. There has been massive deployment of information technology for learning purposes, supervision, and transfer service or transfer information to improve quality of care. Here I'm talking about WhatsApp application platforms, Zoom meeting, the EMPDSR, and other platforms. Also, the development, dissemination of guidelines for maternal and newborn care in the context of COVID, developed by the Family Health Division, paved way for more quality issues to come up. As a result, we have strengthening of triaging at all emergency obstetric care units within the country. Next. Now, at the facility level, however, there's been reorganization of services to introduce appointment system that aim at reducing waiting time at the facility and therefore improving quality of care. We're also talking about implementation and enforcement of national COVID-19 protocols. Here, I'm talking about obligatory use of face masks and in health facilities, hand washing procedures, and then social distancing arrangement that has been. It is good to mention, however, that the identification of isolation centers and designing of protocols for managing COVID-19 positive cases is also one intervention that helped at the end to separate COVID-19 cases from non-COVID. Next. Yes, at the forefront of referrals is the National Ambulance Service, with a total fleet of 350 ambulances across all districts and constituencies. In the time under review, the half year, we've had 11,184 cases being responded to, out of which 10.9% were maternal health issues, whilst 22.1% were COVID-related cases. So clearly, we can see here how COVID-19 is beginning to take a huge chunk of our health supplies. Next. Drones for emergency supplies. Here we have 4 distribution centers across 79 districts. In all, the average monthly deliveries are in the range of the 6,000s. That is figures for May. The main products that are delivered here are blood, plasma, vaccines, and emergency medicines. It's good to note, however, that 1.7% of deliveries in May were COVID-19 samples to testing sites. Next, please. Now, the Kibeli platform in Accra is a WhatsApp-based network of facilities or healthcare providers where emergency referrals are posted to identify the best suited facility to handle the complication in real time. Here, multiple experts advise on management options, where feedback on management outcome, that's successes, failures are reported back to the platform to feed into the growing learning experience. Next slide. Now, you agree with me that not all remote areas in Ghana have access to conventional ambulances. Some communities have improvised transport system, what we call the community emergency transport systems. An example is the community motorcane ambulance in the Upper East region, which has been sponsored by COICA with a total number of 50 motorcane, that is motorbikes, that have been deployed to 120 CHIPS compound or health centers within the community. And these are able to go to areas where usually conventional vehicles can go. Next. So notwithstanding, we still have quite a number of challenges. And I summarize first, the staffing issues. Staff within the reproductive health sector or maternal health issues have been deployed to attend to COVID-19 cases. Some of them, however, have been infected. So we're seeing a situation where we have been dwindling effect on the staff strength. Again, we have an increasing cost of sustaining maternal services due to the increased use of PPMEs and supplies, more than we have used in other times. The next concern is delays in receiving COVID-19 test results for quick decisions during obstetric emergencies, which on its own lead us to use much more PPEs than we usually will use. Then finally, but not the least, I'm talking about shortages. For now, we don't have much of shortage, but we know that if COVID-19 continue to bite, we're going to have shortages in PPEs, blood products, consumables, and essential medicines. Next. So at this point, I say thank you very much, and I hand over to Dr. Yvonne Kiza Mogewa from the MANI project. Thank you very much.
Thank you very much, Dr. And thank you to the organizers for inviting us to make this presentation on behalf of the Kampala Slum Maternal Newborn Project. Next slide. I will start by giving a short introduction of what the project is about. The MANE project is a 3-year USAID-funded implementation research project that is testing innovative approaches to address the demand and supply side barriers affecting care seeking, effective referral and transport challenges, and provision of quality of care for urban poor. We have 3 objectives that you can see there, which are around harnessing the public and private facility mix to ensure provision of quality and affordable maternal newborn healthcare services for urban poor, and also strengthening linkages between the public and private. The important or strategic thing about this project is that it is implemented in partnership with the Kampala City Council Authority. Kampala is the capital city of Uganda, and the City Council Authority is essentially the government authority or the governance arm of the city. So it is strategic in a sense that whatever innovations we pick up or we are able to test and find to be workable are set in a situation that they can be sustained or continued by the government partner. So it is based on this existing partnership that the project was able to use this platform to engage in rapid responses for COVID. More information about the project can be found at that site that is there, the hapnetsite.org. Next slide. So regarding what the project in partnership with KCCA were able to do to promote care seeking for facility delivery, especially within Kampala City, was that quickly an emergency response system was set up. So a toll-free number was secured and publicized in the city, and this number could be called by people in the community for information around COVID, but also, more importantly, for transportation to care. So pregnant women were able to call for transportation to areas where they can receive care, and also those who needed antenatal care were able to call this same number. So this facility was put in place rapidly soon after announcement of the lockdown by government, which was a very rapid thing. But being an implementation research project, we've been able to document and learn from this system how to set up. So this is a kind of new thing in Kampala, and I could say the rest of Kampala, which we are learning from about emergency response also in the COVID context. So since the setup of this system in March, up to say the end of April, the system we had responded to over 3,000 calls, of which 2,000 were about enabling women to go to receive care or children to go for immunization. But what I wanted to pull out in the context of this meeting is that 1,000 of these calls were obstetric emergency related calls. And this was a big thing, a big way in which women within Kampala were enabled to access care. So up to 96% of emergency complications were obstetric, and through this system, they were able to access care. The other intervention made, which was on the previous slide, but it's all right, is that we put in place a 24-hour audit of emergency referral transport care. So we were able to collect data from key facilities providing care within Kampala to examine the quality of care being given to referred women and report on the quality on a 24-hourly basis on a WhatsApp platform that was included key leaders and decision makers so that they could make real-time decisions on how to improve care for these women. So this information was very useful. Next slide, please. And the evidence was used to one advocate for improving transportation or transport instructions, especially for pregnant women, because during the lockdown, there was absolutely a lot of difficulty for women to access care until the rules were clarified that if a woman was pregnant, she could simply access care. The evidence was also used by facilities to improve the triaging of care, to prioritize emergencies, to beef up staff, to campaign for PPE for the frontline providers, the midwives, the ambulance drivers, and also to redirect referrals from congested facilities to facilities that were perhaps less busy so that women could access timely care. The third intervention we put was to take antenatal care services closer to the urban poor. 70% of Kampala's population are urban poor, they dwell in slums. So we partnered with the private sector, with small private midwifery-led clinics to provide antenatal care to these slum dwellers, and the clinics were really in walkable distance from the different slums, and women flocked in for antenatal care, which is something that they were missing. And in a period of about 5 days in this pilot, we were able to see over 1,000 women and direct about 20% of them to receive more further care because they had different complications of pregnancy. So that was another intervention that we did. Next slide. Some of the challenges that we are having, next slide please. Around screening and triaging, the basic principle was that every woman who was referred was quickly taken history from about contact with a COVID patient, but also temperature taken. And if she was found to be suspect for possible COVID infection, then she was redirected to designated hospitals that are designated to provide labor and delivery care for COVID infected clients. Next slide. Some of the challenges that we are facing was one, women still ended up with a lot of unfortunate incidents like delivering on the road, trying to walk to care, because we did not have sufficient avenues to disseminate this information about availability of this toll-free service. The other was that women were hesitant still to come to facilities for fear of infection. And then because a lot of the private facilities were closed, a lot of referrals were taken to what would be the best bet, which was the National Referral Hospital, which was sure to be working. And so this hospital ended up being overwhelmed, and there was overcrowding, and also in other key public facilities, there was overcrowding. And that was really a challenge in compromising spread of the infection as we had planned. There were also limitations in availability of data, because if the data on pregnant women was available, then appointment-based engagements with facilities could be organized. We've also had some challenges in institutionalizing these innovations, especially, for example, the 24-hourly data collection. Next slide, please. Regarding the practical solutions that we propose or that we are trying to look at to promote quality of care for referral transport, I think as Dr. Loveday mentioned earlier, we are trying to use a lot of telemedicine, engage IT to be able to make these communications on the real-time data that's needed for decision-making timely and readily available, and telephone communications between referring facilities to avoid what we call empty referrals, when people are taken to facilities where the service, for example, blood that they need is not available. We also are looking to amplify the citizen's voice. We need to hear from the mothers that are being transported in these referral transport systems about their perspective of the quality of care that they are receiving. As you know, respectful care is critical, but also to hear from them and understand and be able to address any myths and misconceptions that they may have. The other is to really tap into the wide sections or the big capacity that we have in the private sector, that we may be able to harness the private sector facilities, especially the small midwifery-led clinics, to be able to work with them to provide care and avoid congesting the public facilities and thus compromise the quality of the care given to women that are referred. Thank you very much. With that, I would like to hand over to Dr. Loveday.
Okay, thank you very much, Yvonne, and thank you also very much, Chris. I mean, I'm always so impressed when I hear presentations from countries just about how innovative and how hardworking so many health workers are in trying to get as good a quality of care for women as possible in these difficult circumstances. So I've been looking at some of the questions and queries, but please also sort of type some more. I know that there have been a number of questions about sort of digital platforms and how, and this goes to both of you, how quickly can you set these up? How can you sort of manage the contents and the messaging? What are the sort of challenges you've had in these, when you're trying to work with these digital platforms that you're trying to sort of scale up and use very quickly? Chris or Yvonne, could you answer that?
Thank you. The challenges that we are facing in especially setting up the digital platform are to do with, of course, with the skill at the facilities where you, for example, need to be able to access this information or to communicate. For example, with the Zoom training, Zoom-based training that we organized for especially the private sector midwives, it was very difficult to get them all to engage on Zoom. This is just, an IT skill that they haven't yet, been able to pick up. But also more importantly, even as we talk about using IT to get this data in place, the fact of the matter is that the healthcare workers that are already on the ground are already overwhelmed with clients. And so we are finding that you actually need to designate data clerks to be able to provide you this data. And so we're working with some of the other partners to support that kind of cadre of staff, the data entrants, to just be able to take care of providing this data and posting it on WhatsApp or summarizing it and making it relevant. So those are some of the challenges: capacity to use the platforms, but also even capacity to enter relevant data for the relevant decisions that need to be made.
Thank you. And Chris, do you have any comments or responses to this issue around digital platforms and working with them? Okay,
so this has come.
Sorry, go ahead.
Yes, so this has come as a crash program, and we pushing our heads around it, and it is hoped that we'll be able to do much better. For the meantime, what we cannot talk much about is how we monitor the quality of it. But at the end, it is believed that as much as we be able to use that to sustain service, then there is some evidence that there's some quality work being done with those platforms. However, these are things that we could look into in the near future. Thank you.
Okay, thank you. Other questions that have come up, and I think this is always a concern for us in this field, is around sort of equity. And as we know that it's often the poorest women who suffer the most in terms of accessing services. There have been a number of questions about cost and who's supporting these emergency transport systems, and if they're free, and what areas are they reaching? Are you managing to reach all areas? And also another question, sorry, is how whether or not these different community and NGO-led and private sector and national systems are all talking to each other, which is another challenge that we often come across. I wondered if either of you could answer that question.
I'll start with that. Yes, to start with the transport and referral system across the country, as you could see, there are different dynamics. Some, because of the terrain in our country being very diverse, there are areas that are unmotorable. Other areas you might need different strategies. So you see we attacking it from the air, from land, that's roads, and then from very poor roads in small communities. So as a result, when you get to the smaller communities, NGOs are the main organizations that are leading that, and these are coming with specific funding. So the challenge is that when it's like that, they might focus in one specific community and not in that whole big area. So we still have pockets of gaps along which we have to find a way to map up. So it's still a concern how to let all this speak to themselves. If you take the drone project, for instance, there are 4 different stations in divided in the country, but still there are quite a number of pockets left. So I agree that there are areas that we have to address, and we'll keep on working on that. Thank you.
Yvonne?
Yes, thank you. On the issue of equity, again, just to say that what we are presenting is what we have done in Kampala, and clearly it does not speak for the entire country. But for Kampala, that is why we made a special effort to reach urban poor. The slum dwellers, who I mentioned, constitute about 70% of the population in Kampala. So a lot of these efforts to provide ambulance services made sure that ambulances and community pickup vehicles are positioned in strategic places so that the urban poor can also access these services. As I mentioned earlier, the challenge was with the information, because some of them didn't really know about the toll-free number, but even when they did, they also suspected that it's not really free, because it's sometimes rare to have fully free services. So that's the effort that was made to address the equity issue about the poor accessing transport, with ambulances deployed in different divisions in a strategic place, but also community pickup vehicles. I'd like to say about the community pickup vehicles that these were government-owned vehicles fueled by government and just positioned to pick up people who need to move from the communities to health facilities, so that the ambulances could be dedicated to pure interfacility referrals of real dire emergencies or obstetric complications. For the duration of the lockdown period, all these services were free of charge to the user. So the government paid for the fuel, the allowances for the drivers, and all the other things. And going forward, there are different discussions going on how to address or sustain this kind of service, because it is clear that it is needed even post lockdown. So that's the attempt at addressing the issue of cost. About whether the systems are talking to each other, I think one of the opportunities that the COVID response has brought forth is that the systems are talking to each other much better than before. I cannot say that it's perfect, but at least there is real conversation now going on between what the private sector can bring, what the partners can bring on board, what the public facilities can provide, but also listening to voices from the community. So the call center I mentioned had a platform where community members can post their comments, their concerns, and so it is better than it was in the past. Also in the outreaches, we had to engage the community health workers to be able to link with the pregnant women in the communities and to advise on how best to lay out or strategize these antenatal services so that women are able to access the services. What could be done better is the linkage of the different data sets so that decision makers can see the entire picture and make more strategic decisions. Thank you.
Okay, thank you very much, and thank you for those great answers. And it really shows just how complicated these things are and how probably there isn't one solution for everywhere, but just the number of issues that are being raised. And I thought the other issue that you raised that I think sometimes we don't think about enough is, that sometimes these ambulances are used for transportation that isn't necessary. And this whole idea of having facility transport that takes people to facilities, but also ambulances for the emergencies is a very important one. And I think that's very good. Another sort of question that has come up a bit is, for both groups, is around sort of data. So, for example, for Ghana, everybody's very impressed that you have maintained your facility delivery rate, but there are questions about, how do you know about the maternal deaths? Are you worried that some maternal deaths are happening in the community that you're not picking up? Are you using facility data? So I just wondered if you could answer that. And also, sorry, there was a question also about these maternal death reviews, the e-reviews.
Okay. All right. Thank you. Yes. To start with, let me clarify that I'm using national data, which is captured in the DIMS. So these are data sets that we collect from all parts of the country and tabulate at the central level. All right. And therefore, this is much more generalized view, as we can see. Now, when it comes to maternal mortality, it's unlikely that we might be registering deaths in the communities, because even deaths that occur outside health facilities are also reported and registered on our program, on the DIMS, and that is quite robust, because there's no way you can even get to a barrier permit or to be able to do that, bury people without having registered or documented that. So with the system in place, all women that die one way or the other within that period, within that reproductive age, will be captured. That's if they could have been pregnant or have issues to do with pregnancy. So I think that data is near to the reality. However, this is the beginning. Remember, I've captured up to May, and as COVID-19 continues to bite, the situation could be a bit different, but I'm telling you what is happening up to now, and that is quite good. Looking at other areas like the total attendance, yes, we see the attendance dropping significantly, and that's also reflected there. So there is no way to think that there could be more deaths. When it comes to the newborns, yes, that has dropped a lot, and for that, it's a bit difficult for me to conclude that the numbers that we have registered in all facilities are just the true reflection, and there's no way some can be, considering the fact that there are so many remote areas, and when it comes to the newborns, we don't have such a rigid way of registering the deaths. So it's still possible that there could be some escaping from that net. That is my personal opinion anyway, and I wish that probably some of our experts could shed more light to it if there's any of them available now. So in short, I think the data is speaking what could be much more realistic. Thank you.
Thank you. And your colleague, Dr. Isabella have you got any comments that you would like to share or respond on these issues?
Thank you. The only thing I'll add is to re-emphasize the fact that I don't think that we have a very big gap between reality and what is being captured, because we noticed the increase in deliveries. And so if we were having deaths, I think we would also have reflected it, coupled with all that Chris has said. There was also a question about the maternal death and newborn reviews, perinatal death reviews, the e-system. That is quite new. We are piloting in just a few of our regions, and we are yet to scale up, but the paper-based one is ongoing, and that has been, especially with the maternal death reviews, for several years now, quite robust. The newborn perinatal death reviews are catching up. We hope to scale up the e-system, hopefully by the end of the year. Thank you.
Okay, thank you very much. Okay, another question that came up a bit earlier was around the drone program, and just sort of how many commodities and what kind of commodities are being delivered in that program, and does it include family planning and other commodities?
Yes. Thank you very much for the question. Yes, the drone program has quite a number of commodities. We have blood and blood products. Apart from that, all medicines that are considered essential in those communities are included there. vaccines are also included in that program. But to be specific, to mention them all will depend on the communities that are using the service and the type of medication that they usually would like. Example, facilities within the farming communities in the north or around the Afram Plain areas tend to use more of anti-snake venom. That is one of the products that are being transported as a case of emergency majority of the time. So it includes all of that, but more than mentioning them, it depends on the demand in that set of area that will be required. So that, thank you.
So there are some people who I know have asked for more detailed questions about the drone, but I was going to suggest that what we do is that we've kept a record of all the questions, and maybe you could answer that in more detail afterwards. And I wanted to raise a more sort of controversial issue. And I know what is happening is very different in different countries, but in some countries we have heard that women are delivering at home and women are delivering with traditional birth attendants. And there have been some proposals, and I was in a workshop yesterday run by White Ribbon Alliance, where the president of ICM was presenting, and she was saying that we should consider sending midwives to people's homes, because having a skilled birth attendant or a midwife is better than having nothing if they're not prepared to come to facilities. I know you can't answer for all contexts, but in the context that you're working in, is this something that you've considered?
Okay. Yes, in the case of Ghana, I don't think that has come to the table at all, to get midwives to go into the families to do that, some sort of domiciliary midwifery, because there are quite a number of strategies put in place to encourage people to come, and the risk management programs have been quite encouraging. Many more people are free to come. We are getting more attendance at the hospitals. The deliveries have picked up. So we've not seen situations where many more people are delivering at home or are not coming to the hospital to deliver, to prompt us to want to look in that direction. Notwithstanding, if that becomes an issue, we're monitoring closely, we might want to look at that. But again, as part of the challenges I mentioned, we already have shortages with our staff. So go in that direction, unless probably in very small communities where they might not be having many deliveries, we could use that as a platform, as a pilot, but not as a national strategy to be using. That's my opinion personally in a way. But
Dr. Isabella, do you have different views?
Not different, but I want to explain a bit. The situation we have in Ghana is that we operate what we call the community health planning and services, where we place health workers and midwives close to communities, responsible for a cluster of communities, and they live there. So that has made access has improved access. So homes are not far from these centers. And so home deliveries have reduced drastically since we did that. Thank you. And it's not necessary even in the COVID time, because the facilities are very close. The health workers are close to the communities and to assist. If the need arises, they would attend to it, but it's not a big part of our service delivery.
Okay, thank you. And do you have any comments, Dr. Yvonne from Uganda?
Yes, regarding taking the midwifery to the home, I think this is something that's very unlikely to be looked at least in Uganda, because we really have a challenge with human resource, even in the facility. So to be able to organize for midwives to go home to home is something that is very unlikely to be something that will be considered. That said, yes, we do recognize, especially from the stories that we hear from the different rural districts, that women, some of them have opted to try and deliver in try and deliver at home, or even stay in lower facilities, despite the fact that the midwife or the healthcare worker has asked them to move on to a higher facility because of the complications. We've seen that even in Kampala, especially during the lockdown. This was because, you know, women or families could not figure out how they will move from the facility that they're asking them to be referred from. So in a sense, there was a sense in which some women ended up with complications or worsening in lower facilities or even TBA units or something close to that because of the challenges with transportation. I had wanted to say a bit on the maternal deaths issue, the numbers, whether they're going up or going down. I think there were a lot of anecdotal reports especially during the lockdown period, that maternal deaths are going up. It's not yet substantiated by the data that exists, but we do acknowledge that even during the lockdown period, there were a lot of challenges in transportation, even for the healthcare workers, the people who were supposed to enter this data that's informing us. So we cannot really be very solid about the conclusion about the fact that we are not seeing significant changes in maternal death because of that weakness in entry or facility-based data, or even recording what is happening. So we cannot say for now how this has impacted maternal death. We have a lot of anecdotal reports in newspapers, WhatsApp pictures and stories about people that have died here and there, but we do not have a solid response. On the death reviews, we are not yet at the point of our brothers and sisters in Ghana where we can even consider e-reviews. We are still trying to get a grip on the basic paper reviews of maternal deaths and even more so perinatal deaths. But just on looking at the figures, especially in April, there was certainly clear indication from the data that the perinatal deaths had increased, especially if you just look at facility-based perinatal deaths. There were, as you can imagine, increased numbers of cases of ruptured uterus and all the other things that really compromise the survival of the newborn. Thank you.
Okay, thanks a lot. Now I wanted to ask a sort of question that's quite close to my heart, and which is that although the COVID epidemic has created huge problems, both of you touched on the fact that there's been some really interesting innovations that have been developed. There's also been much better communication, it seems, between different facilities and different people. And I think these sort of networks of care, of people talking to each other and people understanding and sort of liaising with each other are very important. And I wondered if you could both reflect on what you hope you can take from this period into how you're going to run emergency and referral services when hopefully this epidemic is over. Yvonne, do you want to start, and then we'll move over to the team from Ghana?
What we hope to be able to take forward even beyond this period is the availability of close to real-time data. I think we have leaped several miles forward from where we were before COVID, and this is something we do not want to see go backwards, because it has been critical in informing especially the referral traffic, so that women do not end up referred to places where they will not receive care, timely care. The fact that they have been referred means they actually need timely care. So that is one thing that we are looking and doing all that we can together with partners to ensure that this goes forward. The other is appreciation of the use of telemedicine or information technology to hold quick meetings, make decisions. In the past, it had to be physical meetings. Where are we meeting? What time? Which room? What? But now it's online discussion. Get to the point. meetings happen on time. And I think going forward, it's unlikely that we are going to revert to business as usual or business in the past, because we realize using this virtual communication, because we are totally unable to move, has shown us that there's a lot that we can cover just virtually and improve mileage. We also in Uganda, the pilot or the emergency medical services network that has been tried out under this implementation research project in Kampala is something that we are looking to provide information on and hopefully have it scaled up to other districts, because unlike our brothers and sisters in Ghana, I saw that fleet of ambulances and said, wow, we don't, we are not yet at that point, but what we are learning from this call center and the ability of communities to call in when they need help and the ability to link them up with ambulances is something we are hoping to be able to learn from and share and scale up to other districts. So actually the Ministry of Health is looking to learn from what we are doing in this implementation research in the context of COVID to see how to scale it up. I think briefly, those are some of the things that we see ourselves taking forward.
Okay, we're sadly running out of time, but the team from Ghana, Dr. Isabel or Dr. Chris, do you have anything that you want to reflect on lessons that you hope you can learn going forward after this epidemic?
Yeah, certainly. Thank you very much. I would start saying that this period is special. By the time COVID is over, at least one major thing I'm sure we will have picked is how to continue on with hand washing and how to improve our hygiene conditions in our society, in hospitals. IPC has been maximized to some level that I think will never return to that level again. So that is one way. Infection prevention and control is one area I think we'll be able to do by far better even when COVID is over. Apart from that, the traditional system, we had many people coming to our hospital, antenatal clinics and filling the whole area and waiting long hours. So you go there, it's just like a market, the scenario you see. Now with COVID, social distancing is another thing that has taught us how to arrange people, schedule them by appointment and things like that. And I think that when even COVID is over, we might be able to have appointment system and maximize the use of time in all our health facilities for the benefit of our clients. The next area I'll look at is the deployment of electronic platforms, which previously we weren't using. People could travel about 700 kilometers to Accra to attend a meeting that will last 30 minutes. But now we could attend about 4 or 5 of such meetings in the comfort of our homes or of our offices. And that is one thing that I don't think we are going to change. We're going to stick to this new platform, which is a way of exchanging quickly information from one group of people to the other. So then we have nurses within the same facility creating different ways of exchanging information among themselves, among other groups within a different facility, and now among other subgroups, doctors and all that. So now information sharing is by far quicker. And I think that going forward, we're going to harness on that to improve the quality of care that we give. Then the last, I think that by the end of this COVID period, the traditional way of doing things, shaking hands so many times when we meet people, we might have forgotten about it and move on to do something else. Thank you.
Okay, thank you so much. I'm afraid we've run out of time, so I'm going to have to pass it on. But I just wanted to say the panelists will answer the remaining questions in our community of practice, and you can join that. And I now just want to pass over to Ted Babb, who is going to conclude the webinar.
Yes, thank you, colleagues. This has been a really informative and very enlightening discussion. I would like to thank all the panelists for your excellent and clear presentation. We have seen how in these hard times how countries are working, innovating, communicating to address really hard, complicating issues. And we have seen also, excuse me, how locally feasible solutions are coming to solve these problems, from service reorganization, using the technology, and also establishing the call centers and the ambulance system, where we have seen in Ghana maintaining the delivery service level, and also the data also was remarkable, where we have not seen increased maternal deaths. And the innovation of the drones was also a very important lesson to deliver these essential supplies, especially blood and drugs for emergency. So we have seen, from these two important presentations, important lessons that countries can use to build better. Some of the lessons, panelists reflected on includes in the IPC capability that now we have remarkably changed in many of the facilities, the call centers established and scheduling services, using the electronic platform, and of course, the behavior change that away with handshaking. These are some of the lessons we have learned. So this is, as you see, WHO has developed this operational guidance on maintaining essential health services during COVID, and also the community-based health care, which includes outreach campaign in the context of COVID. If you have not already done so, please have a look at these resources. They are really useful. And we ask you also, we invite you to stay engaged, check out the continued webinar series in the network website. And also we invite you to register for the next webinar, which is on July 23rd. And it would be on oxygen systems. So I encourage you not to miss that. And also, please join the community of practice and contribute, engage, and learn from your colleagues, and also on the different platforms, including Twitter, using these handles, join the conversation. And also, if you want, to add your contact for the Child Health Task Force, please subscribe on this website. And we have been really happy to engage with you, and we look forward to see you in subsequent webinars. Thank you so much for your valuable time.
Thank you very much. Goodbye.